Good afternoon, everybody. I am Mette Berger, an intensive care physician from the Lausanne University Hospital, and we are going to talk today about the reason why early full feeding are deleterious. Here are my conflicts of interest, none related to the present presentation. First, a definition. What is early full feeding? It is to provide from day one, meaning day of admission, by any route, enteral or parenteral, the total quantity of feeding that you have determined your patient would require, either by equation or by measured energy expenditure. Feeding means extrinsic energy provision of substrates. You'll see why this is important. Where are the potential problems? We're going to go through them. They are essentially metabolic, and some are also intestinal. Let's take first the metabolic risks. It's endogenous glucose production that nobody accounts for. It's overfeeding related to that, the risk of refeeding syndrome, hypoglycemia, and mitochondrial stress that I will not have much time to address, but you may overload the mitochondria. What happens when you, a healthy person, starts eating? Your endogenous built-in endogenous glucose production, which maintains your blood glucose when you don't eat, will drop immediately and then progressively revert over to something that maintains blood glucose in the fasting period. In sick patients, this does not happen. Here, the healthy, you give them some glucose, it stops immediately. Endogenous glucose production does not stop in critical care patients. You see the black bars compared to what they have while fasted. It's very high. We showed this some years back in Lausanne in trauma patients who were admitted to our ICU. Actually, at that time, by day 3, we were so bad at enteral feeding that they were starved. We measured energy expenditure, 1800 calories, slightly over prediction. Patients were normal glycemic. Of course, they had got nothing. And we measured endogenous glucose production, which was 3.1 milligram kilo minute, which translates to 310 grams of sugar being produced, 1200 calories. Look at that. It's 2/3 of the total energy expenditure. It had a price. 117 grams of proteins were lost per day. This is the bar of the trauma patients. We repeated recently with the SPN2 trial, this in patients who were 65 years old and who were partially fed on day 4 and full fed on day 9. Look here, they continue to produce glucose. And if you look at starvation in healthy, you observe that this is a continuous procedure. So this is why it's bad. If you look at total energy expenditure, at endogenous energy production, if you full feed early, you overfeed, which we know is bad and is mitochondrial stress. How do you set your equation? Your targets by equation, most of us now who are interested in metabolism use indirect calorimetry. And the trials conducted with indirect calorimetry to set the goals have had good clinical results. But energy expenditure changes over time, as shown in this evolutive calorimetric study, which shows that when you recover it reverts to normal, methylene can be lower or higher. So it's important to ask yourself if the measured energy expenditure equals feeding needs. Yes, but not in the early phase. And it's very important to remember that while we have had an overwhelming epidemic of underfeeding during the first 7 to 10 days, we have forgotten the risk of overfeeding and the evolutive nature of requirements and the hidden energy intakes from propofol and from glucose 5%. If you overfeed for prolonged periods of time, which means over a week, and this is a paper in 200 patients, If you deliver large amounts of energy, more than half of them, the white bars, will develop bloodstream infections, while if you feed reasonably, this is not the case. What happens if you overfeed? This comes from the burn world, where you have measured energy expenditure here, and you see that more you give, the better the body weight. But the problem is that if you look at this, we now know that over 110% is overfeeding. And what happens? The muscle mass does not increase, the fat mass only increases. So you're actually just making fat. If you overfeed, you overload the patient's liver. And on the top of that, you risk the refeeding syndrome. And this is why we say that in the patients where you have clearly identified that they have a risk of refeeding, you should start with 50% of energy intake and rehydrate. If you don't do that, and this paper was published by Karl Braunschweig and the team, the intention was perfect. I mean, they wanted to full feed patients who were admitted for acute lung injury. And they did what they intended to do, and they used the American equation, which is higher than the European. And they delivered estimated needs 2,100, which is high. And what happened? Actually, the patients had been roughly 7 days in hospital and not fed while they came in. The patients died. The only intervention in feeding which kills by day 4 is refeeding syndrome. They had not measured phosphate. There are intestinal risks also, vomiting, ileus, bowel ischemia. There are actually 2 trials out there. Calories, the British trial, 2,400 mechanically ventilated patients. PN patients, because they were randomized either to full PN or to full enteral. PN patients had less hypoglycemia, less vomiting, an intestinal complication. Nutrirea, 2,410 septic shock patients, more severe. Same thing, randomized to either enteral or parenteral. Significantly more bowel ischemia, acute pseudocolon obstruction, and more vomiting and more diarrhea. This is because they got the full dose at once. So the strategy should be the one here. If you have these 2 curves, if you go up slowly and look at what's happening to your patient and eventually consider supplementing, your patient will do well. This is what we did in the Swiss SPN trial, where we randomized the patients who were not achieving to cover 60% of first goal to either completing with parenteral nutrition or continuing on only enteral nutrition. Goals were set by indirect calorimetry and repeated. What happened? Reduction of infectious complications after the intervention, clearly. So, early full feeding, what should we conclude? While feeding to a goal is required by the end of the first week, and while goal changes over time, the early full feeding is largely responsible for some serious complications in our patients. The principles are metabolic. Early overfeeding, refeeding, hypoglycemia is what we see in clinical settings. We don't have tools in clinical settings to measure what happens to the mitochondria of our patients, but they are overloaded. Intestinal, we should respect the potential of ischemia in patients who are in shock. So this is why we should start progressive feeding, started slowly within the first 48 hours to be ramped up and to cover the needs by the end of the first week. And this is why we now have this tool, which is much cheaper than before and much faster to use. I mean, a measurement takes you 15 minutes with the entire setup. So now you should do that. Thank you for your attention.